Hi there, thanks for tuning in. My name is Mike Rhodes. I'm a veterinary eye specialist and I'm going to be talking to you about which drops to drop, ocular drugs for your practice. May I take this opportunity to say that I hope you're all okay in these crazy times. Hope you and your family and friends are all well given the COVID-19 situation. I have no relevant financial interest, arrangement or affiliation with any company or organisation. So the key learning objectives for this talk include to understand drug delivery options into the eye, to know which topical treatments to stock and what ocular conditions to use them in, and to know which topical treatments are contraindicated for certain ocular conditions. So, keep it really short. Isothalmaxitrol, the end. Bad joke. So moving on. When choosing which ocular drugs to stock in your practice, the following points should be considered. So firstly, is the drug licensed to treat the ocular condition? Something we're going to talk a lot about in this talk is the fact that most topical ocular treatments are not licensed for what we want to use them for. So therefore we have to prescribe off license and use the cascade. We also need to think about owner compliance. Owner compliance is a massive problem in human beings with eye problems. Studies have been done to show that owner compliance on themselves is terrible. Therefore, taking that information onto their own animals, if they can't be trusted to treat themselves, then how can they be trusted to treat their pets? And we'll talk a little bit about the ease of application, how often they have to be applied, etc. This links into formulation of the drug. So if we're putting something into the eye, it can be a drop, it can be a gel, it can be an emulsion, it can be an ointment. Ointments are definitely my formulation of choice, but a lot of owners don't like that because they're harder to put into the eye. Really key point of this talk is also the ability of the drug to penetrate into the eye. The cornea specifically, the eyeball has evolved to prevent things going through it, drugs being one of those things. So to get a drug to go through the cornea is actually quite challenging. And that's important if we're treating a condition that's on the surface or a condition that's inside the eye. And also what the drug does, the mode of action, what types of drugs are there out there. And I've tried to simplify it, talking about antibiotics, anti-inflammatories, etc., etc. We're going to go through all the different drugs in this talk that I think are relevant, because there are a lot of drugs out there that I don't think are relevant. At the same time, the caveat with this whole talk is a lot of this is my own opinion. You might speak to another ophthalmologist who doesn't agree. Hopefully, because I do work in general practice, I am a specialist who travels around and works out of first opinion practices and have been in practice. Hopefully I can get the balance right between a drug that is effective, that's not too expensive, that's available, etc., etc. So, on to the first point, prescribing off license and the cascade. So how many topical drugs are licensed to use in domestic animals in the UK? Well, there are 7. For varying things, we've got Optimune, Clinagel, Isothal, Albanine, Tiosil, Opticlox, and quite a new drug, optocycline. Now, next question is, which of these drugs is actually licensed to treat corneal ulceration in our small animal patients? And the answer is Clinagel. Now, Clinagel is gentamicin. Gentamicin is certainly not my first choice to treat an ulcer. The reason being, it's very epitheliotoxic, it's irritant, and it's very narrow spectrum. However, if we're being totally going by the veterinary licensing system, theoretically, if you have an ulcer, you should be prescribing Clinagel. However, we're going to come back to that, and I'm going to put forward an argument of why I think potentially we should be using slightly different drugs to treat ulcers in our domestic species. So when we are prescribing off license, which the majority of the time we are, because there are very few drugs licensed for our animal eyes, we have to follow the cascade. So if there is no drug available that's licensed to treat that specific condition in that species, then a vet can use a vet product licensed for another species or for a different condition in the same species. The next level is a human product authorised for a similar condition. The next level is a vet product authorised in another member state that's been imported. And then finally, it's a home preparation. But whenever we're prescribing off licence, we need written consent. This is an example of the consent form that I use. Obviously, I'm an ophthalmologist. All I'm seeing all day are eye cases. Therefore, every case I'm seeing is going to have some off-license medications. Therefore, to save time when a client comes to see me, I will write a list of the drugs that I think we're going to be using, and they will sign it at the end of the consultation. So I'm getting consent for the drugs that I'm going to be using off-license. So now to compliance. Now, these are a couple of examples of human studies that have looked at compliance. So in the top study, humans treating themselves for glaucoma. Glaucoma, not quite as bad as in dogs, but in people it's pretty bad. You could go blind, you could lose your eyesight. So what they did is they looked at three things of clients treating themselves for glaucoma. They looked at the patient log, so when they gave a drop, they logged it. They looked at an interview, so they interviewed them afterwards to see when they did it, and then they actually used an eye drop monitor, and you can see, so that's what they actually used. And you can see there's a disparity from the patient log, the interview, to actually what they did. I mean, it's almost 20% disparity, which is quite concerning. Another probably slightly more relevant to our veterinary patients are parents treating their children for strep pharyngitis. Only 10% of the parents completed the 10-day course. 11% never started treatment, and 80% received treatment for 4 to 6 days. So this is parents treating their own children for strep pharyngitis, not a life-threatening but a serious condition. And this study demonstrates that they didn't follow protocol. What does this tell us? That pretty much everybody lies, and I think, although that's a bit of a joke, it is relevant to our domestic species, because a lot of these, what we do is reliant on the client going away and treating their patient, their dog or their cat, and because we know that there's a chance they're not going to follow the instructions, it's important we try and make the whole process as easy and stress-free as possible, which, as you know, is not always possible. So when we're actually talking about eye treatments going into the eyes, we can have a drop, we can have an ointment. Now, drops are definitely easier to apply, so going back to compliance, that's going to be a tick in the box for the owners. However, if you put a drop into an eye, it's probably gone within about 10 seconds. Therefore, in order to reach a concentration of that drug on the eye, on the ocular surface or in the eye, you need to apply that drop very frequently, which is a cross for the compliance issue with the clients. Ointments, which are my preference by a long way, persist for much longer. So you put that ointment into the eye, especially if it's a paraffin-based ointment, it's going to be sticking to the cornea, it's going to hang around, it's going to achieve a much higher concentration of the drug, which is exactly what we want for it to have its effect. However, it's harder to apply, which is a big thing in compliance, and clients are not going to like that. The other reason not to go for an ointment is if you have a perforation or a communication between the outside of the eyeball and inside, an ointment getting into the eye is not ideal. A gel is essentially in between an ointment and a drop, but in my feeling is it's closer to a drop, because a gel, when it warms up, does become very liquid-like and is therefore gone quite quickly. The other thing is how much to apply, and less is definitely more. The reason I say that is when we talk about drops and we talk about the actual tear film compartment, the volume of the tear film compartment in our domestic species is about 10 microliters. The volume of the conjunctival sac is about 30 microliters. That's a total of about 40 microliters. The average eye drop is between 25 and 70 microliters. These are the drops that come out of the eye bottle. Therefore, in some ways, a lot of these drops are actually we're giving too much for this system. And the problem is, if you put too much into this system, all it's going to do is it's going to activate the nasolacrimal apparatus. It's going to pour out of the eye. Less is definitely going to be more, because the drug is going to be gone and it's not going to be on the surface where we want it to have its effect. Often it's a really simple point, but often clients say, well, what is the best way to apply a treatment to the animal's eye? I think it is very much a personal preference, but the big thing I've learnt over the years, it's about if you've got the ointment, if you're coming at the dog or a cat like that and it moves, you could poke it in the eye. If you rest your hand on the animal's head, as in this photo, you can drop it. If the dog or cat moves, you can move with it. And again, this is the same thing with a drop. Now, with ointments, I think one of the big things to help with the compliance is to put the cream in one's pocket before applying it. It brings the ointment up to body temperature, which makes it more liquid-like, makes it much easier to apply, which I think is really important. So the next topic we're going to discuss is ocular surface versus intraocular disease. So I've already briefly mentioned the cornea is very difficult for drugs to penetrate. Some drugs penetrate better than others. So when we are treating an ocular condition, we need to ask ourselves, is this a surface disease or is this an intraocular disease? Therefore, when we're choosing a drug to treat that problem, is that drug going to be able to get to where we want it to get? So, for example, this is a German Shepherd. This dog has chronic superficial keratitis, also known as pannus. Now, this, as we all know, is an immune-mediated condition affecting the cornea, the surface layers of the eye. We have corneal neovascularization around the limbus into the cornea. We've got pigment deposition, we've got cellular infiltration, we've even got some lipid in the middle here. So we want to use a topical steroid to treat this, to get on top of it. We want a steroid that potentially is very potent, but we're not worried about a steroid that is not going to penetrate very well. So my choice would be a drug called Maxidex. This is dexamethasone. It doesn't contain the other antibiotics that Maxtrol does. These antibiotics can be irritating to some patients. Dexamethasone is actually very poor at penetrating the cornea, so for a case of intraocular inflammation, it's not very good. For something like this, that's surface disease that we want to get to, then Maxidex would be a really good choice. Conversely, we have a dog with anterior uveitis. The inflammation is inside the eye. We need to get the drug to penetrate the cornea. Therefore, we want to go for Predforte. Predforte isn't as potent as dexamethasone, but it's very good at penetrating the cornea and getting inside the eye. So now we're going to move on to an overview of ocular drugs. We're going to talk about antibiotics, antivirals, anti-inflammatories, anti-glaucoma drugs, anti-melting drugs, lubricants, tear stimulants. mydriatics, hyperosmotic agents, and bandage contact lenses. So we're going to start with antibiotics. So I've chosen 3 pretty standard antibiotics that most of you will have on your shelf or probably should have on your shelf. Whenever we're using an antibiotic, we need to think about using that drug either prophylactically or therapeutically. So, for example, if we have a non-complicated ulcer in a non-brachycephalic dog, it's a scratch, you just want to give that animal some antibiotic to prevent that eye getting infected, to facilitate the healing process. That is what we term a prophylactic antibiotic. And I think isothal is a good example of a prophylactic antibiotic. We're going to use it in a non-complicated ulcer to prevent infection. Isothal, as we'll talk about, is quite narrow spectrum, good against gram-positives, which a lot of the commensals are, but it's not very good if we have an active infection going on. Compare that to chlorphenicol. It's a bit broader spectrum. Chlorphenicol can be prophylactic or therapeutic. And then we come on to Exocin, which really is our sledgehammer. Exocin is for our infections, especially involving Pseudomonas gram-negatives. And we'll come on to that in a bit more detail, but Exocin's more of a therapeutic drug. So just to give you an idea of when we're using antibiotics, we're using prophylactic, therapeutic, or both. So isothal, it's narrow spectrum. It's good against gram-positives, it's quite good at penetrating the cornea, and it's with a carbomer gel. And the advantage of it being with a carbomer gel is that it can actually be used once a day. We tend to use this as a prophylactic rather than a therapeutic drug. Good example of that, if you have a cat with a suspected superficial corneal ulcer due to herpes, you could use the isothal once a day as a preventative measure to stop that ulcer getting infected, to allow it time to deal with the herpes, to move forward. We don't want to be stressing this cat out, we don't want to be treating it excessively, and therefore the once a day isothal is definitely a good option. Another situation, we've got a traumatic ulcer in a dog. It's not complicated, it's not a brachycephalic. We want to use the isothal as a prophylactic treatment rather than a therapeutic treatment. In this slide we have an indolent ulcer in a dog, and essentially what we're trying to show here is that the isothal is another option, sort of a sorry I'm gonna have to go back on myself here, sorry. This is a rabbit. That's why I hesitated there. It's a rabbit ulcer, and I think isothal would be a reasonable choice as a prophylactic treatment in a rabbit with an ulcer. However, we come on to a much more significant ulcer. This is a dog with a very deep ulcer. This ulcer is progressing, this ulcer is infected, we've got stromal loss. And then there's a photo of a pug with an ulcer in the top there. This is a situation when we wouldn't want to be using isothal. Isothal would not be a good choice in this situation because it's very narrow spectrum and we have probably a gram-negative infection going on. We need to be starting to think about doing cytology, doing a swab to see what bugs we're dealing with, and probably reaching for the stronger antibiotics such as Exocin and chlorphenicol. Chlorphenicol is very broad spectrum. However, there are some gram-negative resistance situations. So if we do have an infection where we suspect Pseudomonas aeruginosa, chlorphenicol would not be a good choice. It's written as being bacteriostatic, however, at higher concentrations it becomes bactericidal. And if we're thinking about using chlorphenicol ointment, especially on the ocular surface, it is likely to be cidal rather than static. It's the least epitheliotoxic antibiotic. It penetrates the cornea well, and we can use this as a prophylactic and a therapeutic agent. Again, chlorphenicol ointment would be my preference over drops. So, an example of when to use the chlorphenicol ointment. This is a boxer ulcer or indolent ulcer. Scared. These dogs have very superficial ulcers. They have an inherent defect within the anterior corneal stroma which prevents the epithelium from sticking down. This dog has had a grid keratotomy. It's got distichi which are insignificant. But from the point of view of a choice of an antibiotic in this situation, it's not infected. We're using it as a prophylactic rather than a therapeutic, but it would be a good choice because it's the least epitheliotoxic antibiotic. In this situation, we have a cat with conjunctivitis, and with feline conjunctivitis, the main differentials would be feline herpes virus and Chlamydophila felis. Using chlorphenicol ointment would be a good choice, more from both a prophylactic and a therapeutic. So from a prophylactic, it would prevent any further infection. From a therapeutic, if this was down to Chlamydophila felis, we might get some clinical improvement from using the topical chlorphenicol. However, it's really important with Chlamydophila felis that topical treatment alone will not cure the problem because it affects the whole cat. These animals need systemic antibiotics such as doxycycline. Then we're on to Exocin, ofloxacin. It's very good against gram-negatives, but there is some gram-positive resistance. It's bactericidal and it has good corneal penetration. It's good against infections of Pseudomonas, and we tend to use Exocin as a therapeutic agent. I used to really like siloxane ointment, ciprofloxacin, but unfortunately Alcon stopped making this, so I tend to use a combination of chlorphenicol with Exocin, based on the assumption that chlorphenicol does become bactericidal at higher concentrations, therefore it's fine to use in combination with the Exocin. It covers both the gram-positives and the gram-negatives. In saying that, it's always a really good idea when you have a progressive ulcer or an ulcer in a brachycephalic to do cytology, to do a swab, so you know exactly what bugs you're dealing with. So a good example is a pug with a progressive ulcer. You've got stromal loss there. We're going to take our cytobrush, we're going to do cytology. And this is the situation, especially if we feel that there are gram-negative rods there, that we should be starting our Exocin against the Pseudomonas. A relatively new antibiotic called optocycline, which is chlortetracycline, is good against staph, strep and proteus. It's also reported as being good against Pseudomonas aeruginosa, and it's bacteriostatic. We tend to use this therapeutically, but also we can use it in SCEDs, these indolent ulcers and boxers, because studies have shown that tetracycline antibiotics do help these ulcers heal in the long term. We're now going to talk about antivirals. So we're talking about our cats really with our feline herpes virus disease. Most cats, in my experience with ocular disease, have herpes, and the problem with herpes is it can be hard to prove whether they have it or not. You get false positives and false negatives. Therefore, there's an argument not to test them, to treat and see how they respond. The antivirals we have available are the famciclovir, the ganciclovir, and unfortunately this cidofovir is not available yet, but hopefully it will be soon. Really important take-home message with feline herpes virus disease in cats is that less can be more. Whenever we do anything with a cat, whenever we give them tablets, we give them eye treatment, it stresses them out. Because of the nature of feline herpes virus infections, any stress, any increase in endogenous corticosteroids will cause a recrudescence of the virus, will cause the virus to take a hold on that patient. So we need to really minimize stress. So less is definitely more. Some examples of feline herpes virus ocular disease. This is a dendritical, so this is pathognomonic for feline herpes virus, and it demonstrates the pathway of the nerve fibers within the cornea. Often you don't see this lesion because by the time you see it, they've actually developed a geographic ulcer rather than just this small thin line. Another example of feline herpes virus infection in cats is this is a kitten with ophthalmia neonatorum, and they tend to get an infection under the eyelids before they open and then get a delayed opening of the eyelids. So you need to open those eyelids up really gently and get that pus out of there. We can have conjunctivitis, a bit like that previous case. The differential will be chlamydophilus. And then again, we can get this dendritic type sort of branching ulcerative keratitis, which is pathognomonic for feline herpes virus infection. So how do we treat? Famciclovir has been proven. Lots of studies from the States have shown it to be safe and effective against feline herpes virus. The dose is very variable. The recent studies from the States are talking about a dose of 90 milligrams per kilogram BID. Some ophthalmologists recommend the dose of 30 milligrams per kilogram BID. Personally, I tend to use 125 milligrams BID per cat per os for 5 days. We have to be careful, as in with antibiotics, of using too low a dose because we could induce viral resistance to the drug. Gangcyclovir, this is Vergan eye gel for people. Gangcyclovir is a topical antiviral agent. We need to use this 3 or 4 times a day. Now, there's no studies to show how effective this is in the live animal, but in a case where clients haven't got much money, I think Gangcyclovir is a good option as opposed to Famciclovir, which is very expensive. The main issue with this is we don't fully know how effective it is, but I know lots of colleagues who think it's very effective. Cidofovir is a very, very effective topical antiviral agent. The problem with it is it's so expensive. So a small vial of this antiviral agent is used for intravenous treatment in people. It costs about £1,000. The beauty of this is they've shown in studies that if you make it up to an ocular preparation, it will work twice a day, whereas most antivirals topically are virostatic and you have to apply them very frequently, which is then counterproductive because it stresses the cats and makes the viral disease worse. Hopefully on the horizon, as the price of this drug comes down, this will become effective because this will really change how we can treat cats with herpes ocular disease. Okay, so we're going to move on to anti-inflammatories. We're going to talk about Predforte, Maxitrol, Maxidex, ocular, and Yelox. So Predforte is a potent anti-inflammatory agent, not as potent as dexamethasone, but the good thing about it is it's very good at penetrating the cornea. However, we've got to be careful of using any topical steroid in cats because of the herpes virus recrudescence. If we assume that all cats have herpes to some extent, we can then have problems with chronic corneal ulcers if we use it. The other thing you've got to be careful of is, especially if a client has it and uses it infrequently at home without telling you, you can get corneal melts, which can lead to corneal perforation, as in this dog. This is a cat with anti-uveitis, very chronic. Again, in this case, I would be worried about using Predforte just because of the risk of recrudescence of herpes virus. The other side effect of long-term use of topical Predforte or any steroid is corneal lipidosis. So we do have to be careful of using Predforte, especially if there's lipidosis already present, because it will make it worse. So Maxitrol is dexamethasone with several antibiotics. neomycin and polymyxin B, which can actually be quite irritant. So if you do have a dog that you're treating, say, for an allergic conjunctivitis, you can actually make them quite sore with the Maxitrol. Personally, I really like Maxitrol because, again, it comes in an ointment, and as you all know, I'm a big fan of ointments because I think you achieve much higher drug concentrations with the ointment compared to a drop. Really important thing to take home from Maxitrol and Maxidex is they have very poor corneal penetration, so it's more for a surface superficial disease. Maxidex is better than Maxitrol in some ways because it doesn't contain the antibiotics that can be irritating. Topical Yelox, this is a non-steroidal anti-inflammatory drug. It's actually almost as potent as Predforte, has good intraocular penetration, and the good thing about Yelox long term is you don't tend to get many side effects like you do with the steroids, and you don't tend to get the corneal lipidosis. If you have a really inflamed eye, you can use Yelox in combination with Predforte because the Predforte and the Yelox have a synergistic effect. You can use it with corneal ulcers, but it's not ideal. It will definitely slow the healing process. I know some vets feel that Yelox or topical non-steroidal will make a corneal ulcer less painful. That's not true. All a topical non-steroidal will do is delay the healing process. Ocular, personally, I don't use much Ocular because I think Yelox is better. We're now on to the anti-glaucoma drugs. We're looking at Travatan, Duotrav, Zalatan, Zalacom, Azopt, Azaga, Trusopt, and Cosopt. So Travatan, Duotrav, these are our prostaglandin analogues. They are the most potent intraocular pressure lowering drug that we have. They cause rapid miosis. However, they're not very effective in cats, and they are contraindicated in anterior lens luxations. This is what can happen when you apply a drop of the Travatan. It makes the pupils very small. This is a terrier with an anterior lens luxation, and this is a contraindication for Travatan, Zalatan, Duotrav, Zalacom. The reason being, if the lens is in the front of the iris then shuts down, you're going to get a pupillary block, so you're actually going to increase the intraocular pressure. So that is when we would not want to use it. The other caution with using these drugs is if you've got marked inflammation, because prostaglandin analogues will make the inflammation a bit worse. However, when you're looking at all the evils of glaucoma and uveitis, sometimes glaucoma is the worst of those evils. Therefore, it's better to use the Travatan or Zalatan even if you have got a bit of inflammation, because it's important to get that pressure down. So Azopt, Azaga, carbonic anhydrase inhibitors. So Azopt is brinzolamide, Azaga is brinzolamide plus timolol. These work by reducing the production of the aqueous humor, whereas the prostaglandin analogues increase the outflow. They're less potent than the prostaglandin analogues, but they can work well together. So if you do have a case that's not responding just to the prostaglandin analogues alone, you can add these drugs and they work well. The brinzolamide is better tolerated due to the more neutral pH. But again, this drug doesn't work very well in cats. Trusopt, which is dorzolamide, is similar to brinzolamide, but it has a slightly more alkaline pH, therefore it can irritate the eyes, especially longer term. However, this is really the only option we have in cats. Cosopt is the dorzolamide plus the beta blocker, and in my experience, Cosopt doesn't tend to have much more of a pressure lowering effect than the Trusopt alone in cats, but you've got to be careful because you can get systemic absorption of the beta blocker and associated bradycardia. We're now into anti-melting drugs. So this is a situation when you have an active melting process going on. we have options serum or plasma, we have EDTA, and we have tetracyclines. My personal preference is serum. I think serum is readily available, especially if you collect it and freeze it and have it in your practice freezer. EDTA I don't think is that effective, and especially when what most people do is they use an EDTA tube and put a little bit of sodium chloride into that. I think the concentration of the EDTA in that mix is so small it's not going to have much of an effect. Something that is quite interesting is the chlortetracycline, which is this new drug that we're using to treat indolent ulcers. I've used it in a few corneal melts and it seems to be quite effective. So serum, we collect it from healthy dogs and we freeze it, and it can be viable for approximately 6 months. You can use it in cats. What you can't do is use serum from cats in other cats because of the risk of viruses being spread. So here we have a corneal melt in a cat. You can see that the corneal stroma is essentially turning to mush. And this is a situation when we would use these anti-melting drugs. Plasma is definitely worth looking at. This is the liquid cell-free part of the blood that has been treated with anticoagulants. It has the same efficacy versus serum, and you can actually buy plasma from the PET blood bank. It's probably a little bit more expensive than doing the serum and freezing it though. We're now on to topical lubricants. Again, different people will have different preferences. I'm a big fan of paraffin-based lubricants. Used to be Lacrolube, you can't get that anymore. So Vitae Pos and Xalin Night are both paraffin-based, white paraffin-based lubricants that don't contain preservatives. Viscoteers, Lubrithal are fine, but because they're a gel, they tend to not hang around as long, but clients do prefer them. And then you can get Remend lubricating gel, which again some clients do like. Again, I'm not convinced that it hangs around as long as the thicker paraffin-based creams. Onto tear stimulants to treat the dry eye. Optimune is our licensed product for dry eye and for Panis, so we need to go for that first. If Optimune doesn't work, by all means try the cyclosporin drops, because Optimune is 0.2%, so you can make your own drops in corn oil with the cyclosporin, go up to 1 or 2%. My feeling with that is that it tends to be quite irritating when you get to the high concentrations, and there are tacrolimus options available. Tacrolimus is much more potent than cyclosporin. You can get it as a protopic ointment, which is a human skin cream. You can also get Bova make a 0.02% eye drop, which some clients quite prefer. The problem with the protopic is it's a very thick cream. It's in a really big tube, so a lot of clients don't like getting that into the eyes. You do need to be really clear with the tacrolimus as being off license, because the protopic is a cream that they can absorb, and if they haven't been instructed to wear gloves and to take precautions, and also you haven't obtained written consent, you could find yourself in trouble with that one. And then pilocarpine. Pilocarpine is an eye drop, but we use it in neurogenic dry eye, which I'll talk about shortly, to stimulate the tear gland systemically rather than topically. So, neurogenic dry eye. Neurogenic dry tends to be in dogs, it tends to be unilateral, and it usually presents with a zero tear production. So one eye is normal, one eye has zero tear production. Now, sometimes, but not always, they will have a dry nose on the same side. This is because the nerve that innervates the tear glands also innervates the glands of the nasal planum. Sometimes you can also have other neurological deficits, for example, facial nerve paralysis. So here's an example of a case. This is a middle-aged collie crossbreed that's presented with a left-sided tenacious mucopollulant ocular discharge and discomfort. You have a look at it, you do a Schirmer tear test, there's no tear production on the left side, the right side is normal. You have a closer look. Also, the nose on the left-hand side is quite dry. We have a look in the ear just to make sure there's no obvious ear disease going on. But based on the clinical examination, you have a strong feeling that this is neurogenic dry eye. This is a diagram that I'd like to thank an ex-colleague, Carolyn Chewett, who drew this diagram, which is really, really good because it does show how the innervation of the lacrimal system works. But here we have the cranial nerve 7, the greater petrosal nerve, coming to the pterygopalatine ganglion, which then splits, going to the nasal glands of the nasal planum, and then to the lacrimal gland. So if you do have an issue with a disruption in the process along this part here, then you're going to lose both the nasal gland innervation and the lacrimal gland, hence the dry nose. You can still have a disruption further up, hence the nasal gland is unaffected, but that's why usually you have the dry nose on the same side. Now, the way we treat this is with oral pilocarpine, 1 or 2%, and we titrate to effect because different dogs really respond really differently to different amounts of this drug. Big dogs can react really badly to it, small dogs cannot react at all. You tend to get something called denervation hypersensitivity, whereby the lacrimal glands become really sensitive to these parasympathomimetic drugs. We start it at 1 or 2% drops. We do 1 drop 3 times a day. We increase every 3 or 4 days until we get side effects, hypersalivation, being sick, loose stools. Say 5 drops 3 times a day lead to side effects. We stop it for 24 hours and then we restart on the 4 drops and we keep going. We're trying to get the dog on the maximum dose of drug it can tolerate. We then monitor the tear production. Now, the majority of these dogs with neurogenic dry are idiopathic. If they respond, 50% of the responders actually can start producing their own tears again, so it's just something to be aware of longer term. Now we're on to mydriatics. These drugs dilate the pupil. They also have an effect of relaxing the ciliary body. Midracil tropicamide is the sort of gold standard in the sense of it's quite short acting. It doesn't take very long to work. So in a dog and a cat, it will work in about 20 minutes. It will last for about 3 hours. Atropine is more potent. It's much better at relaxing that ciliary muscle. But it takes about an hour to work, and it can last up to a week to 10 days with 1 drop in a healthy eye. I often see vets where they get really stressed about the pupil still being dilated from 1 single dose of atropine. Just be aware it can last. Atropine also can affect the tear production, so beware. But the big thing with mydriatics is if you're worried about a high pressure, do not dilate the pupil. Dilating the pupil shuts down the angle and can, if you've got an animal that has high pressure or is on the way to getting a high pressure, it could tip them over. So if in doubt, you need to check the animal's pressure with a tonometer before you apply a drug to dilate the pupil. Hyperosmotic agents, this is sodium chloride 5% ointment. We would use this in a situation when we have a condition called senile endothelial dysfunction. This is definitely more common in certain breeds like the English Springer Spaniel. They tend to get a bilateral, not always symmetrical, progressive corneal edema due to the loss of the endothelial cells. As the dog gets older, these endothelial cells normally act as water pumps, so the cornea becomes waterlogged and can lead to edema, can lead to loss of vision, can lead to ulcers. So the idea of the hyperosmotic agent is it pulls the water from the cornea and prevents any ulcers and reduces the level of clouding. In reality, if you're doing it 3 times a day, it can work well in some cases, otherwise it can make them sore and sometimes doesn't work that well. And then we have to go for surgery, either in the form of a thermokeratoplasty or quite a new procedure in the form of a corneal cross-linking, whereby we use UV light, riboflavin, which actually changes the physical structure of the cornea, increasing the links, which can hopefully not increase the clarity of the cornea, but it can stop these ulcers forming and make the animals more comfortable. Bandage contact lenses, I'm a big fan of. In my opinion, there's not many situations where they are contraindicated. I think they can be used in ulcers. I think they can be used with ointments, with drops. And in my opinion, what happens with the medication you're putting into the eye can almost become sequestered into this contact lens, which can actually be beneficial. These are the lenses we use. They're the Bausch & Lomb Pure Vision 2 bandage lenses. They have no refractive power, and they're made out of a slightly more permeable material. Using some local anaesthetic, we take the lens, put it on a cotton bud, and we pop it straight into the eye. So, to summarise, anterior lens fixation, don't give it Traviton or Zalatan. Corneal ulcers, avoid topical steroids and non-steroidals. If you have a corneal ulcer in a pug or a brachycephalic, do not use isothal. Use something a bit stronger. Cats, avoid topical steroids, avoid Traviton or Zalatan. And also in cats, less can be more, assuming that most cats have herpes as a cause of their ocular disease. Stressing them out and over-treating them can make their conditions worse. Well, I hope this has been a useful talk. I hope there's been some take-home messages there that are useful. But time to reflect. I think a big thing I want to reinforce is that most topical eye medications are not licensed for veterinary use. Therefore, it's important to follow the cascade closely and obtain written consent. Is there anything you're going to do differently? Hopefully the contact lenses are going to be something that you can take home, and you can order those directly from Bausch & Lomb, and one size fits all. You don't have to go through measuring the size of the cornea. May I take this opportunity to acknowledge colleagues for some of the images used. Christine, Heidi and Peter, thank you very much for all of your help over the years. I'd also, for those of you interested, like to tell you a little bit about myself. I graduated from Edinburgh, spent 4 years in general practice doing the old Royal College certificate, went into a residency at Willows and stayed for 10 years, and then recently felt I wanted to do something different. Felt quite disillusioned with corporatisation and set up Focus Referrals 3 years ago, and it's been a really interesting experience, and we're hoping to change how we work. At the moment, we work out of 4 first opinion practices. This is Miles, my vet nurse colleague, with his adopted French Bulldog Mariah. And what we're hoping to do is actually base ourselves in our own building within the next 6 months, which is really exciting. Anyway, stay safe. Hope everyone stays well in the current climate. And thank you again for taking the time to listen to me today. Thanks.